So let's review the differential again, and then we'll chat through about what would you do? How would you manage this patient? Okay, so why don't you guys start again? Let's review the top the top potential diagnoses here. Or what's on your differential again?
So, Prof, we talked about an expansile lesion at the apex of the temporal bone on the right side, and we mentioned possible lesions that could cause this. We mentioned cholesterol granuloma and congenital cholesteatoma.
Mm-hmm. Right. Was there anything else we talked about? Or is there anything else you can think about or think of based on this location, the anatomy?
Well, we also said it could have been a tumor, it could have been a meningioma. Yeah, I think those are the main ones you came up with. I don't know if we spoke about chondromas or chondrosarcomas.
Right, right, exactly right. We mentioned that. Remember, why would there be a chondrosarcoma here? What's the precursor to that, and is that what would be that precursor here?
We said the joint between the temporal bone at the apex and the occipital bone, as well as the sphenoid. At the joint, we will have some.
Do you remember what that? Yeah, do you guys remember what that's called? In between the joint. Do you remember what that?
It means slippery slide or slide. Right?
Oh, you mean the clivus?
Yes.
Right, and then there's a little slip of cartilage typically between there, right? Petroclival synochondrosis. We talked a little bit about that. Maybe, does that term ring a bell?
Yeah.
Yeah, that could be a precursor for that. So chondrosarcoma. What if the lesion was more in the midline? Which, what if it was right in the midline behind on the clivus? What could that be?
On the clivus.
Kind of right in the midline, potentially.
Like a meningioma or in the midline.
More in the midline, not off to the side like this. You ever heard of a clival chordoma or
Okay.
ring a bell? Maybe ring a bell midline. Yeah. So you guys mentioned meningioma. It's possible, but is there anything you might find or might see on a CT scan to suggest that it is more like a meningioma? So if you saw this film, you're looking at it, is there something that would say, oh yeah, well, that could be, we'd have to get another maybe imaging study. What might that be off a CT? Is there anything that might give you more of an indication that it would be meningioma? Knowing what meningiomas might do or what they sometimes have characteristics of, is there something on a CT that might tip you off?
Like a intense lesion on the scan. Contrast, if you use the contrast.
Maybe, but but what would you be looking for? Is there any feature on that?
If the pathologist told you it had Samoma bodies in it, what would that tip you off to look for on the CT?
I'm not certain.
So what's white on a CT scan? So you're looking at a CAT scan. What if you saw something white, like in the middle of that lesion, you saw some white spicules or more calcifications? Exactly right. Right. So some of you ever heard of a calcifying meningioma? Sometimes a meningioma can have calcifications. A lot of times they're fibrous, but sometimes they can have calcifications. And so if you look subtly on a CT scan at a lesion, you might see something and say, oh, that looks like there's some calcification there. That might tip you off that you need additional imaging. Yeah. All right, here's a really good question. I'll give you a little Dr. Welling just mentioned Samoma bodies. Okay. There are four pathologies that I know of that have Samoma bodies. Other than meningioma, can you name them? And if you can't, I'll give you a little way to remember these. Kind of a anything else you can name?
Never, I haven't read about these nobody's.
Samoma bodies. So we already talked about one is meningioma, right?
Yeah,
How do you spell Samoma bodies? What's the first like 4 letters, 4 or 5 letters?
PSA
Uh-huh.
MOMA.
Got it. So the P, the S and the A, and the 2 M's are your answers.
wow.
So P is papillary thyroid carcinoma. That can have Samoma bodies. The SA is serous adenocarcinoma of the ovary. The next one is mesothelioma. And then the last one is meningioma. So there you go. Now you know your 4 tissue types or pathologies that may have Samoma bodies. Papillary thyroid carcinoma, serous adenocarcinoma of the ovary, mesothelioma, and meningioma. There you go. Good way to remember that.
Yeah, yes.
So you may want to look at those Samoma bodies up on again on histology. They're kind of like little nests of cells. I may have a slide on the other. We'll talk about that. I think I may have a slide for you on that one, perhaps. Okay. So yeah, so we talked about now what else could this be? One other thing. What if the patient had pain behind the eye, maybe a draining ear, maybe an abducens palsy?
Wernicke syndrome.
Yeah.
Wernicke
Which is
syndrome.
also called what?
Petrous appendicitis.
Petrous appendicitis, right? So yeah, and that's not likely here because the patient, of course, you're looking at the patient. Are they toxic appearing? Do they have fevers? Do they have all these physical findings? But again, that's something else to think about, right? And then sometimes, if you look at the left side of this Petrous apex, it's highly pneumatized. Sometimes that pneumatization can simply have some fluid signal in it. It can be asymmetric. So oftentimes radiologists may call the asymmetry that you see in variably pneumatized Petrous apices as something pathologic. So you have to look at that closely. Okay. All right. So what do you guys want to do now?
Can I ask you about one more thing on the differential? That
Yeah,
I-
sure.
I
Sure.
might have seen once as a mucocele, where they don't
Yeah.
consider it actually,
Mhm.
and maybe that's somewhat analogous to what you're talking about with the differential in terms of the
Yeah. Mhm.
apex pneumatization or not. But mucocele is another thing which is, I think, pathologically distinct from, say, a cholesterol granuloma or
Mhm.
another possibility.
Yeah. Yeah. The other thing too is may not be thinking about too is arachnoid granulations sometimes. Very rare. But if you guys have ever seen arachnoid granulations, they're like finger-like projections of the arachnoid that kind of infiltrate into bone. They can be very erosive as well. And so you have to look at that. So sometimes but usually that's along the posterior fossa, a little bit more laterally, typically near the mastoid. You might see a series of finger-like projections that are going into the bone that are somewhat erosive, but those would be like arachnoid granulations. And then the last thing we talked about, maybe we mentioned it last time along the lines of benign pathology would be a lipoma, right? Just a fatty tumor in the Petrous apex. Okay. All right. Yeah. So now with that said, what do you guys want to do with this patient? So how do you advise them? What do you want to counsel them? And then is there anything else you want to do?
Well, so depending on the history, if it was an infection, then we would have thought about treating if we had a Petrous appendicitis, if we had to treat conservatively first and see whether it makes any progress. If we are not progressing, then we might have to do like a mastoidectomy. But if we are dealing with the tumors and whether benign or malignant, then at least from my reading, I realized that the accessibility to these lesions are very difficult. So we tend to depend on the scans we have, CT scans, MRIs to make their distinctive features to make a diagnosis. And I think if it is very small, if the lesion is small, you can watch for some time, see whether it's causing some compressive symptoms or is causing any significant hearing loss or neurology. But if those effects are increasing, then the options will be to surgically intervene, depending on what you are dealing with.
Okay.
And different approaches of surgery have been described.
Yeah, we'll talk about those in a little bit, but I guess the question still, Dr. Sirajuddin, what do you think about do you feel happy with this? Do you know what the diagnosis is? How confident are you? Is there anything else you want to do for this patient?
In terms, so not fully, I don't have 100% assurance of the diagnosis. I could consider getting further imaging or doing a endoscopic examination to visualize the actual lesion. But I think I would probably preferably go for an MRI, maybe, perhaps to get more distinctive visualization of the lesion and more definitive. And more so what's it just to be able to see to visualize it better.
Okay.
With more detail.
Okay. What are you expecting to see on MRI? Is there anything particular that you're looking for?
Just really the characteristics of the mass and to see involvement of how high up does it involve? Does it go to the base of the skull? Is it coming from the brain? Is it coming from the meninges itself? Or I mean, obviously we don't think in this case, but to rule out things like that and to see the safety of surgery and determine how we would approach it.
Okay. What if the patient, as you said, this is an incidental finding, right? Remember, you did a glomus tumor on this patient back in the day, and they don't have any cranial nerve deficits at all. And you have this finding. All you have is the CT. And if resources are limited or whatnot, the patient says, I can't afford the MRI. I can't get it. Are you okay with that? How would you advise them? What would you say that probably the diagnosis is? And then what would you say you might want to do?
Well, so Prof, if we can't go on to do an MRI, we would advise the patient to be coming in. We could maybe schedule the patient for 3 to 6 monthly follow-ups to see whether there are any changes, hearing, neurology. So we examine the patient every now and then to see whether there's anything going beyond what we saw the patient at, or how the patient was at presentation.
What about drainage as a part of so you could try to do some drainage, because if it's a cholesterol granuloma and you want to confirm it, couldn't you do some drainage as part of your therapy and investigation to get a sample, which would then tell us what it contains, and then we can know if it's a cholesterol granuloma.
Okay, well, tell me how you do that. How would you do that? If you're suspecting cholesterol granuloma, how would you, in this situation, how would you drain it, or how would you find that out? And if the patient is asymptomatic is that indicated?
Oh, no. So if they're asymptomatic, then I'm not sure it's indicating at all. And I would,
If this patient said, you know, I've got bifrontal headaches. I got bifrontal headaches here. And then they ask you, do you think this lesion is this spot on my skull is causing that pain? What do you think? How would you answer that?
because
They're not complaining of retroorbital pain or the ear is fine on the exam. There's no fevers. They're not showing any signs of systemic infections. There's no cranial nerve findings. They just have bifrontal headache. Would you say, oh, wow, that's, what do you tell them about that symptom or those symptoms and this?
I don't think it's related. It could be, but I don't think so, because usually where this is cited, it would give you that retroorbital pain. So that's what I'd most be thinking about, because of the trigeminal involvement.
So if the patient says, well, okay, if it's not, then, but what if they say, okay, maybe I do want you to sample it. How would you sample this? Is it that easy? Is it something you could do in the office? What are you going to tell them? How, Peter, maybe this would be something you want to, I'll kick it back to you.
Yes, it's not easy to access the Petrous effect. And the morbidity associated with the surgeries is something to take into account. So if the patient is asymptomatic, or if the main thing is a headache, a frontal headache, we could try some analgesia, but to access it, you might have to go transsphenoidal or retrolabyrinthine, or all those approaches are very, like, if you are going through the temporal bone, for instance, then you know that you might not be preserving hearing, for instance. So it's something that we would have to be sure we want to go in and do a lot before you attempt anything. It's not as accessible as it might look. That's what I think.
Okay. We'll come back to that in a little bit, but okay. So what if the patient says, I really want to get an MRI? Okay. I'd like to get one. So you get one. Okay. And so you get this MRI and this is what you see. So, let's see. Why don't you guys, one of you guys go ahead and tell me what you see. Can you walk me through this a little bit? How about you, Dr. Siraj? Why don't you start? How about tell me what you see first here.
We can see a contrast.
First of all, what is it? What kind of scan is this?
Okay, so this is I can't see the orbit. It is T2 rated. I'm assuming because the meninges look like orbits, no? So I think it's a T2 rated image. I can't see I usually would comment on the orbits and see some fluid.
Where else could you see fluid that tells you if it's a T2 or not? Where else might you see fluid that's easily seen at this level?
The meninges and CSF, I guess.
Sure. So what about, you're at what level here?
Sorry?
What structures are you, what level are you here? What structures are you seeing? Is this a coronal, sagittal, axial?
Axial image of a patient, and at the level of I can see it's in the maxillary sinuses still. I can see this is structure. I can see the beginnings of the extra-auditory meatus.
And right at the internal auditory meatus there, or the porus acousticus, what is that big space right there? There's a big gray space right there. What is that? Do you guys know what that is? What's a collective term for that?
Prof, please, can you point with your
Yeah, I'm
cursor?
sorry. Here. So this is the internal auditory canal, right? This is a big space here. What's filling this space?
CPA angle.
Right? And what's a cistern? Do you know what a cistern is? Have you heard the word cistern?
Basal
Distance.
systems.
This is a lot, yeah, this is fluid here, right? Cerebrospinal fluid. All
Okay,
right,
so
so if this were, does that help you determine if that's a T1 or a T2 rated image?
okay, so it's a T1 image.
Right, so you have a T1 weighted axial view of an MRI, right? And it's hard to tell. Sometimes you can see if you have contrast by looking at the nasal mucosa, there's a little bit of maybe contrast here. And so you're at the level of the cerebellopontine angle, right? And so describe what you're seeing.
So you can see a enhanced mass in the right Petrous apex. So CP angle, cerebellopontine angle. It's quite well demarcated. And it's got smooth borders mostly. And, what else can I say about it? Doesn't seem to be destroying any structures around it. It seems to be just an expansion.
What if I told you that on T2 weighted image, which I don't have, that it's also bright? It's bright on T2 and it's bright on T1 with contrast. What would that tell you? Based on these characteristics.
Oh, that it's got blood in it. I assume it's got some sort of, well, I'm guessing because if it's enhanced on the T1 image and T2, which is showing fluid specifically, then I'll be going more towards something containing blood or
fluid. So so in that location with how it looks, if it's bright on T1 with contrast, bright on T2, does that help you make a diagnosis?
Well, then I would be thinking about a cholesterol granuloma because they contain blood. They are mostly it's bleeding with granulation tissue formation and inflammation. So I would be pointing towards that sort of diagnosis.
Okay. So what if it was isodense on T1 or hypodense on T1 and it was bright on T2? So let's say you get this film, T1, it's not very enhancing. It doesn't enhance much, but on T2, it's bright. Does that change your potential diagnosis? And what could it be?
I'm not sure.
And Peter, you can chime in on that one too, if you'd like.
No problem.
Any idea?
T1,
I'll give you a hint. It's in our list of the differential, right? So if it's not bright on T1, but it's bright on T2, is that likely a cholesterol granuloma?
So that means if it's only button T2, that means it's mainly fluid.
And it's isodense on T1 in that location, what would be possibly more likely a diagnosis of what we talked about?
Is it a meningocele?
Nope, not likely. Could be. I mean, it's possible, but not likely. Possible, but not likely. But that's a good guess, though, because if it's if you're talking about it just like an arachnoid cyst or something, that's a possibility. Yep.
Yeah.
But given that where you saw the bone, what Dr. Welling mentioned it last week, and you guys mentioned it this morning. What are we taking out of the ears most of the time? What's the most common tumor we take out of ears? I'm sorry?
Cholesteatoma.
Cholesteatoma, right? Cholesteatoma. Absolutely. Yeah, exactly. And I'll give you guys a table here at the end that shows you some of the different things. So, so the point here is that this is, it's really important to think about T1, T2, the nature of the lesion. Is it expansile? Is it lytic? Is it erosive? In this situation, the location, bright on T1, bright on T2, likely cholesterol granuloma, right?
Okay.
Okay. Okay. So let's talk about then, let's talk about how you would approach that. So if you're you guys mentioned approaches, how would you approach that? So, and what would be the indications to approach it? So we talked about the patient's asymptomatic, correct?
Yes.
Yeah.
So would you necessarily operate on it if they're asymptomatic? Just some frontal headache?
I don't think so.
Mm-hmm. Right. Probably would just observe it. Dr. Welling, what would be your surveillance on that if you had a patient like this? Incidental finding, maybe a little bit of diffuse generalized frontal headache, no other cranial nerve neuropathies, has this identified lesion. How
I
would
would-
you advise the patient?
I'd probably check a CT again in 6 months, and if it hadn't changed much, maybe a yearly thereafter. But I'm not certain that the frontal headache wouldn't necessarily be wouldn't be related to this. I mean, it depends on the severity of their headache and how, if they can treat it with Tylenol or something minor, I probably wouldn't be too aggressive. Also, it'd be helpful to have a coronal so we can see how low it goes. There's maybe a straightforward way to drain it that wouldn't, I mean, not
Right.
straightforward, but easier.
Right. Right. Yeah, I don't have a chronal on this one, but right. So no, I agree with that too. I do the same thing. So I have several patients that have, these are incidentally found, and I'm following them. They're asymptomatic, incidental findings. Just because it's there doesn't mean you have to operate on it. Most of the time, cholesterol granulomas, as you guys will learn, they're very challenging to manage because of the access. The most ideal, as you guys mentioned, was the transsphenoidal. But as you can imagine, if we go back to this, 1 second, let's go back and switch screens again. If you go back to, oop, I had too many presentations open here, I think. If you go back to this one here, there's a potential corridor through the sphenoid to get into this, right?
You have to go ahead and
But you have to think about the optic nerve. You have to think about the carotid artery. The nice thing about transsphenoidal is that you can provide a conduit that can drain outside the nose, down the nose, right? Because cholesterol granulomas are going to have a lining, and they're going to have this kind of a oily discharge, like a viscous, thick, like black, oily type substance. And so unless you keep that open and give it a place to drain, they can reaccumulate easily. And so that's why they're so challenging. But oftentimes you don't have this nice little access through the sphenoid to drain it, keep it wide open, allow it to drain, and even potentially strip away some of the membrane there that might be responsible for some of the production and expansion. So I don't have a coronal for you to show, but let's talk about if you can't go through the nose, what are some of the other options to get through, to get to it? Peter, you mentioned a couple of these. How can you access the Petrous apex from a temporal approach, transmastoid approach? Are there some ways that in your studies and surgeries that you've used to get to the Petrous apex? What would be a common one? Probably one of the most common approaches is what? And either one of you guys can answer, whoever might know. Dr. Welling.
You call on me?
Sure.
Yeah, I think that there's an infracochlear approach where you can go in through the mastoid and go underneath the cochlea and drain it if it has that much extent inferiorly. And that may be a way to get drainage. It's not necessarily a great way to clean out the lining. And some people will put a little silastic or something to try to get drainage into the air cells of the middle ear. The other approach is to do it through the middle fossa. Just come kind of to Kawasi's triangle anterior to the internal auditory canal and open into it that way. And you, again, you have probably better access to clean it out from the middle fossa than infracochlear, given its location above the internal auditory canal there. It's still somewhat challenging, and I think there's a little controversy about whether or not you have to really strip all of the lining off of it. I try to do that if we're going to go through the middle fossa, but Google Fish used to say, oh, if you follow them all for 30 years, they'll recur if you don't get all the lining out. But I haven't followed all of these for 30 years, so I'm really not sure if that's true.
Yeah, right. Yeah, exactly. So one of the most common approaches, and again, this is where the CT of the coronal would be important. So when you guys are, if you think about how you've lifted a tympanomeatal flap and now you're looking in the middle ear, you're staring at the promontory of the cochlea, right? So, you know where the basal turn of the cochlea is. Below that, when you get down in the hypotympanum, you can follow that right under the cochlea to the Petrous apex. Now, there's a couple of big structures down there you have to be careful of. If you're down in the hypotympanum and you're below the cochlea, what two big structures do you have to think about not getting into? Either one of you guys can answer that.
Extrage.
Prof, so the internal carotid artery and the jugular. We were
Sorry, we were
Right.
muted.
So the carotid, right? The carotid artery, and what's posteriorly in the hypotympanum?
posterior.
So if you're drilling below the cochlea,
So apart from the jugular bulb,
the bulb, right? The jugular bulb, right? Exactly. So it's the jugular bulb and the carotid artery, right? So you have to be very careful there. And if you drift too posteriorly too, you can go through the dura and you get a CSF leak. Okay. So it's not an easy access point. You guys should look at that. Peter, if you go back to the temporal bone lab, you should lift the tympanomeatal flap or look at it on some of your cases. Now, a good way to practice this so you have a better idea about this approach is to take one of the canal wall down mastodectomies you performed in the temporal bone lab, because now everything's wide open. And then find the basal turn of the cochlea and try to drill under there, find the carotid and the jugular bulb, and then extend straight toward the Petrous apex.
yes, Prof.
So that's a direct route. That's an infracochlear approach Dr. Welling's talking about, where you can actually access the cholesterol granuloma and drain it. But the problem is keeping that conduit open, because sometimes, as I mentioned, if you guys have seen any of these drained, have you seen Tashneem drain any of these, Peter?
No, Prof.
No, yeah. Right. So when you get into them, you guys have all seen oil that comes out of a car, right? You used oil, very thick, dark, viscous. If you open that up and you drain some of that over time can dry and crust and re-close off the hole. So some people will, as Dr. Welling said, will put as like a silastic tube or sheeting in and roll it, create some kind of conduit, but even that can get plugged as well. So knowing the temporal bone anatomy, now you've gone, now here on this picture, we went on the front side of the ear canal, right, anteriorly. Are there some ways to get to the Petrous apex through the mastoid that you could also utilize?
So, the infralabyrinthine approach, the translabyrinthine approach, the infracochlear, the transcochlear approach.
Okay, those are pretty destructive approaches, right? You're going through the inner ear. What about ways of not going through the inner ear if you're trying to preserve hearing and balance?
We mentioned the middle cranial fossa approach.
Uh-huh, okay. And then, but anything else here? What about, what's up, what structure's up here? See where my
The
arrow is?
infratemporal fossa approach.
The, what's that?
Infratemporal fossa approach.
Right, but well, there's also what's the third balance canal that normally lives right here? What's this?
The nasal septum.
Nasal cavity.
No, so you're in a left mastoid here, right? You guys, let's orient each other here first. So you're opening it. This is a mastoidectomy of a left ear, correct?
Yeah.
This is the tegmen. This is the tegmen mastoideum, right? Here's the ear canal. This is the mastoid antrum.
I think
This is the horizontal semicircular canal.
Sorry,
This is-
Prof. Looks like you're on a different picture. We are seeing something different.
What do you?
we're not seeing. what
We
the-
are still seeing the MRI you showed.
Oh, you are. Oh, I'm sorry. Hang on a minute. Oh, I'm sorry. Hang on. I brought up too many. Okay. It doesn't overlay that. Sorry about that. Give me 1 second. Sorry about that. Let's do this. Let's bring that down. Oops. Okay, what are you guys seeing now?
Prof, we are
Do you
not
see-
seeing anything. There's
Do you-
nothing.
There's nothing. Okay, 1 second, 1 second. Technical difficulties. There we go. How's that?
Yeah,
Yeah.
now it's-
Okay, sorry about that, guys. What are you seeing here?
So you can see the jugular.
Are you seeing a cartoon schematic? Or are you still seeing the MRI?
No, we are
Cartoon.
seeing that.
Cartoon seeing a jaw.
Okay, got it. Okay. So does this picture make sense?
Yes, Prof.
That's a signature.
Yeah, so this is a left mastoid, correct?
Yes, Prof.
Yes.
Yeah. So on that, what other approaches could you take to get to the Petrous apex? So you mentioned infracochlear, we mentioned middle fossa. You also mentioned going through the cochlea, going through the labyrinth, so transcochlear, translabyrinthine, pretty aggressive, right? We probably wouldn't do that for benign pathology like a cholesterol granuloma, right?
Unless their hearing was already gone.
Correct. That's correct. What other approaches that would be non-destructive to the inner ear that you could utilize to get to the Petrous apex, other than what we talked about?
Yes. What about a zygomatic, going through the zygomatic arc and through the glenoid fossa?
I wouldn't. I suppose you could, but that would be, that you're kind of going outside the temporal bone there. If you're going into the TMJ, that's not typically an approach people would take. What about through the mastoid here? So you're in the antrum, right? What lives right here above? So if you open the rest of this bone and you went deep into this area, what structure lives right here?
You see the incus?
You'd see the incus, certainly. You'd see the horizontal canal, but what's deeper in here? What is this structure right here, guys?
Superior semicircular.
No, the lateral semicircular canal.
Lateral or horizontal semicircular canal. What is this structure right here?
Posterior semicircular.
Okay, so what's missing? What would be right here?
Superior semicircular canal.
Right. Sometimes, so some people it's pretty rare. You can go under the superior canal into what was the name of the air cell tract in here? You guys ring a bell? There's sometimes blood vessels that run under the arch of the superior canal dome. Have you heard of the subarcuate air cell tract, subarcuate artery? That can live in that area. You can go this route. Some people might go retrolab behind Again, more risk of getting into the dura right here because this is where the anolymphatic sac lives, right? In the posterior fossa. But those are two and other routes that you can go in addition to infracochlear, transsphenoidal, and middle fossa that are not ablative. Certainly you can go through the inner ear, but again, we're trying to avoid that.
My,
Okay.
my thought on that would be that those are the most difficult to get to because the,
Mhm.
at least in this case, the cholesterol granuloma is so anteriorly located that
Right.
going through the subarcuate area, you'd come to the posterior fossa where the subacute artery comes into the canal there, and you'd still have the internal canal in front of you before you get to the
Yeah.
cholesterol granuloma. So I think it would be difficult. And going
Mhm.
retrolateral again, you'd run into the internal canal before you get to the
Mhm.
cholesterol granuloma. So
Right.
I like the other
I
route
agree.
better.
Yeah. I just mentioned them anatomically, historically, but I think I've never personally gone those routes.
Yeah, I wouldn't either. I don't think I could get there from that route.
No, no. Yeah, exactly right. Yeah. Um, but you can see that the challenges of these things. So oftentimes, I mean, your career, Brad, how many of you operated on for drainage of these?
Less than 10, I think, probably,
Yeah. Yeah.
you know, one every 3 or 4 years, not very often.
Yeah. Right. Exactly right. So I've only done a couple, two, three myself. Yeah. Okay. So good. So let's go back one thing here, guys. Let me switch screens again. Let's kind of review what we just chatted about. 1 second. Here we go. Okay. Here we go. Okay. So, so just to review then, so the differential, we kind of covered a lot of these, right? So cholesterol granuloma is your most common. Remember, it's bright on T1, bright on T2. You don't necessarily have to operate on it. You can access those through some limited approaches. But patient selection is really important here. You have to make sure you're doing the right surgery for the right indication, and is the indication truly there? Okay. Chondrosarcoma, we talked about that. That's obviously, malignancy that's usually at the midline. Going to present a little differently, right? The bone could be a little bit more moth-eaten. Sometimes it looks like a popcorn kernel, a popped piece of popcorn with the fronds and the little lobules at the petroclival synchondrosis. It's not going to have that smooth or expansile look that a cholesterol granuloma has. Plus, on imaging with contrast, it can be sort of heterogeneous. It's not going to be so smooth and uniform with enhancement. A lipoma, a fatty tumor, that's going to be bright on T1, right? Maybe not bright on T2. That can happen because that's marrow bone, marrow-like bone in the Petrous apex. We already talked about cholesteatoma, epidermoid cyst, right? Hypo or isodense on T1, bright on T2. Clival chordoma, that's going to be more midline, right? So if you have a big midline lesion, this isn't usually going to be off to one side or another. The location on that is critical. We talked about arachnoid cysts or maybe encephalocele. Those are going to be like frond-like projections sometimes into the bone. And of course, the Petrous apicitis, Grad-Nigo syndrome, they're going to have clinical findings, right? The retroorbital pain, maybe abducent palsy from the sixth nerve in Dorello's canal that's getting compromised because of inflammation and infection. They likely need an MRI because you have to worry about maybe having an intracranial abscess, right? So these patients can be really present with and be really sick, right? White counts are very high, fevers, they look toxic. They need a lumbar puncture if it's really gotten to that point. They could develop meningitis, so pretty severe, right? So remember cholesterol granuloma, a couple of pictures here, you just saw those, right? So these are cysts in the Petrous apex. Usually it's from, the old blood product from the kind of marrow-like bone that gets broken down. So sometimes they'll call these chocolate cysts, blue dome cysts, usually from the contents. We just talked about this. They can present with all kinds of different symptoms. And maybe, Dr. Welling can comment on this as well, is that many times patients, once they find out they have one of these, all their symptoms are related to that. They'll say, yeah, oh, it must be that cholesterol granuloma that's causing X, Y, and Z. Yeah, they can have certainly these types of symptoms, but you have to kind of consider that in a clinical context, because once people know they have something, they oftentimes will fixate on that and think that's what's causing a lot of their symptoms. So, you have to
certainly warn them that if you do
Mhm.
operate, it doesn't necessarily mean those things will go away. So.
That's right. That's right. Exactly right. So we just mentioned this on MRI. There's, they're bright on T1 and T2. And CT scan obviously shows kind of a smooth, erosive / expansile quality. We talked about management, right? Observation typically is what you need. Drainage, it can be curative if it's for the right indication. You want to try to look for the easiest way to drain these things because they're not trivial. So wherever you're practicing, if you've got somebody that feels comfortable with transsphenoidal surgery into the cranial base, that would be an ideal partnership, because you may need them to help you drain those types of things. But then usually they'll recur. So that's the challenge of this thing. So you have to counsel the patient also that there's a high likelihood that it could come back. Okay. Condor sarx, we mentioned this. So there's an example of what that looks like. So if you look at the CT up above, that's an axial view of a left temporal bone. And if you look just posterior to the carotid artery, do you see how that near the Petrous apex there, near where the clivus meets the Petrous apex, you see how that's not an expansile smooth. You see how it's roughened, kind of irregularly shaped bony lesion, right? That if you look at the correlative MRI, now, Dr. Siraj, is that a T1 or a T2 down below? That MRI, can you tell me, is that T1 or T2 and why?
Is a T1.
Okay, why is it a T1?
The meninges aren't lighting up.
Say that again.
The meninges aren't lighting up.
Okay. Peter, do you agree that that's a T1?
Probably, we said the T1 lesions were the ones which will show a bright meninges, or the fluid containing areas will be bright. So this doesn't look as bright. So I think it's a T2 lesion.
All right, so you need a tiebreaker. Either Dr. Welling or Rasmus is going to have to give you guys a tiebreaker here. Which one? What do you guys think? T1 or T2?
Go ahead, Rasmus. Your turn.
Rasmus, are you still there?
Yes, I'm there. It's
Yeah.
it's
What do you
T2.
think? Is that a T1 or T2?
It's a T2.
And why do you say that?
So in addition to the basal systems that you talked about, I also sometimes look at the inferior or middle turbinates. So in T2, they will remain a little bit hyper intense, even in fluid suppressed T2 images. So you may need to go to the nose and check the turbinates.
Mm-hmm. Yeah, but I think you hit it earlier, though. This is a T2 weighted image, because if you look at the cisterns, look at the fluid around the brain. T1 is not going to give you that kind of signal. Okay. So even look at the part of the cerebellum here. Do you see some of the fluid signal, CSF? You're not going to see that in T1. Okay. So this is important why you guys want to look at your own films. Look at them, look at them, look at them, look at them. Okay. Really important.
I'm sure you've heard the little catch. H2O is T2 bright. So anything that's water shows up
Mhm.
on T2s as bright images.
Mhm. Yeah.
T2.
So it's important to toggle back and forth on MRIs between T1 and T2, T1 with contrast, T1 without, and then T2s. And then there's a whole slew of different sequences they'll give you, diffusion weighted, all these different things. Depends on where you are. But the bottom line is fundamental differences between T1 and T2 imaging is really important to go through that. So, but you can see in this T2 weighted image, you can see some of this heterogeneity of the tumor. It looks like a piece of popcorn that's been, popped. Kind of has this frond-like irregular shaped areas. So those are things to look at there. That wouldn't be a cholesterol granuloma, right? So, those are the kind of, again, characteristics. So because, we can't readily biopsy these things in the clinic and even readily biopsy them in the OR. There's some effort involved. And so we really rely on imaging characteristics to make these diagnoses, okay? These, obviously people can operate on these, depends on the location, depends on, and many times they're subtotal resections given the location, and then sometimes folks will just radiate the residual. This is just demonstrating that there's a whole host of symptoms that patients can present with these types of lesions. So again, it depends on the size, depends on the location. But again, it's always important documenting symptoms. This is more for, again, more like a board style case. This is just some of the different types of chondrosarcomas, the subtypes. I won't go through that. And then, of course, Grad-Negro syndrome, right? This is the Petrous apicitis. In addition to the clinical findings on imaging, you may find kind of enhancements or erosions of the bone. You may find fluid signals, extradural or even intraparenchymal inside. So these are the types of situations where you definitely would need an MRI, because if you see something like this, where you've got an intracranial abscess, obviously that's a neurosurgical, issue that needs to be drained. Patient needs to be on antibiotics, obviously admitted, IV therapy, all that kind of thing, right? But again, these types of patients they're going to present differently, of course, than somebody who has a cholesterol granuloma, right? So this is not an inclusive list, certainly, but it highlights the importance, and the point that I want to make is sitting down with something like this and going through all of your MRIs and your CTs and looking closely at how some of this common pathology will present on T1 and T2. Okay. So I think that the take home today is really look at all your films, practice on each other and say, hey, okay, show me what you're looking at, and be able to have a good command of the language. Say, okay, we're looking at an axial T1 weighted MRI with contrast at the level of the internal auditory canal. So what I'm seeing here is right? It's kind of a thinking out loud process, but it helps you kind of go systematically through these films. So first, obviously identify, is it a CT, is it an MRI? What plane is it? Is it have contrast or not? What's the weighted sequence if it's an MRI? And then start looking at the pathology and start talking through that. Okay.
Can I add one little
Yeah,
thing?
certainly. Yeah.
The thing that's changed in my practice time is just that with cholesteatomas, our radiologist will now also do diffusion weighted imaging.
Yeah.
And that will that'll show up as a bright lesion if it's a cholesteatoma. So diffusion weighted imaging is helpful, because otherwise cholesteatomas are kind of nondescript. They're sort of isointense. They don't really look. It's not distinctive, but with diffusion weighted imaging, it's quite clear that it's a cholesteatoma.
Yeah. Are you guys seeing those on MRI? Have you seen this thing called DWI?
We do them for the follow-up for cholesteatoma.
Yeah, good. So you guys are seeing that. Exactly right. Yep. Those are nice particularly in situations if you've had an ear canal that's been overclosed. Say, for example, you've overclosed the ear for whatever reason, you physically can't look in the ear. Those are nice to have those so that you don't have to go back and reoperate and do exploratory surgery. Yeah. Erasmus, do you have DW? Are you doing diffusion weighted imaging on your MRIs?
Yes, I think since I came back, I've done two of them, and these are patients that I had done before I went for my fellowship. And fortunately, they are all good. They're still good.
Got it. Okay. All right, guys. Well, we're about out of time, but nice. I hope this is kind of helpful. I'm again not trying to make this punitive, put you guys on the spot, but sometimes it's good to be able to just, you know, think through this kind of thing. Questions, comments?
We just have to go and relook at the differentiation between T1 and T2 weighted imaging.
Yeah. So with every patient you see, you really should spend some time if they've had imaging, you know, with patients that get imaging, really spend some time. And what I would encourage you to do before you read the radiology report is look at the film yourself and see if you see what they see. I would say probably half a dozen times a year, I'm calling radiology saying, do you guys see this little spot in the cochlea? I think maybe you missed there's a little enhancement here in the basal turn. Is that maybe that's a little schwannoma? Or they miss a little something too. You know, they miss stuff too. So probably half a dozen times a year. This isn't routine, but I find that I see things that they may not have commented on, or at least prompts me to call them and say, is this artifact? What is this right here? What are you seeing? But I would say look at the films yourself and don't look at the radiology report yet. Look at it on your own, then go back and maybe validate it with their report.
Yeah,
That
I
makes
completely agree with that. I think that as surgeons who deal in this area, we should be able to read these images as well or better than they do, just because it's crucial to what we're going to do for the patients. And I agree. I never read the radiology report before I've had a chance to look at the films myself. Somebody sends me a report, I say, I need to see the films. Don't, you know, the report's not helpful. I want to see the films.
Yeah. Plus also it kind of plants in your mind what you might be looking to see. I'd rather you look on your own and have your own systematic way of looking at the film. Then you can go validate it with the report and say, oh yeah, oh, they're seeing that too. Or does that make sense?
Yes,
Yeah. So just get in that habit of doing that. You'll be thankful later. Plus it gives you better command of the anatomy. It really just does. Okay. So next week we'll keep doing some cases. And if you guys have some interesting cases you want to talk about, so I'm not monopolizing it all the time. Brad, if you have a couple of interesting cases you want to maybe talk about next week, or Erasmus, that'd be kind of nice if you guys are up for that. Otherwise, we'll keep going with some additional cases that I may have.
Right.
Okay, I'll contact you during the week if I have any interesting cases.
Okay, sure. Yeah. The ones you want to present and chat about. Or Peter, do me a favor, ask Tashneem if she has any particular cases that you'd like to prepare for next week that you want to present. And even if they're garden variety cases, you can talk us through about how you manage them. So, you know, maybe an advanced cholesteatoma that was involving the cochlea, or you know, maybe you had she had a glomus tumor, or an interesting you know, any kind of case. Maybe I want to ask her if she has some interesting cases to talk about, and then drop me a note. If not, then I'll have something ready.
Yes, Paul.
But we'll continue to do some case-based things like this for a little bit longer.
Okay.
Sound good?
Yes,
Yeah.
please. Thank you very much.
All right, guys. Have a great happy Friday.
Thank you. You too. Have a good weekend.
Thanks, Brad. See you later. Take care.
Thank you.
Okay, Erasmus, can you stick around just for a minute?
Yeah, sure.
Yeah, great. Okay, excellent. All right. Well, I hope Clements, I feel bad because I think maybe he's somehow on the African Neurologic Society, maybe there was some maybe missed his email or something. I apologize for that. So yeah, I got to make sure he's on the list. So yeah. What I wanted to do was to confirm the dates. I'm trying to make sure that I have the exact dates that I would need to be in Zimbabwe for the T-bone course. Yeah.
So it's the Monday and Tuesday, which is 22nd and 23rd of April. We have an audiology conference in Victoria Falls.
Okay.
Then the temporal bone course will be starting on Wednesday, which is 24, and ends on Friday, which is 26. So the week of 22nd April to the 26th of April.
Okay, got it. Okay, so the only problem I have there is interestingly, that's the exact same week we have a temporal bone course here.
Okay.
But what I can do is I'm going to talk to my colleagues about covering that because I usually teach, there's 4 or 5 of us here.
Uh-huh.
And I teach on the 20, my day is always on the Friday. So my day would be the 26th.
Mhm.
But the course starts on the 24th and it's 25, 26.
Yes.
Okay. Okay. Got it. Okay. The audiology course, tell me about that. If for some reason I couldn't make that, would that be okay if I came in on Tuesday? Is that, or how does that work? How would that work?
No, I think that should be fine if you can't make for the audiology workshop. It's the first one that we are trying to organize between audiologists and speech therapists. They've never had a
Oh,
combined workshop themselves.
okay.
So I've seen some gaps in terms of management of patients and for them to understand now what we can,
Okay.
So we decided to coordinate for their first meeting.
Okay.
So
Okay.
yeah, I don't think you really have to be there for that one, but we should be able to manage. And I understand but there are some colleagues from the UK who are coming over, so they will help us on that,
Okay.
especially Chris and then Professor Macharia from Kenya.
Got it. Got it. Okay. Okay. Because I just have to look at the calendar. So what I would do is fly to Harare then, right? Is that what I
Yes.
would do if I got, because then what I was going to do was go to Cape Town
Mhm.
for the week after that for just
Okay.
the fellow work.
Okay.
So if I came in,
Mhm.
because you guys will be, well, you'll be in Victoria Falls. How far away is that from you guys from Harare?
So it's about an hour's flight away from Harare.
Oh, so you'll be there and then you guys are flying back.
Yes, so that one is mostly Clemens who is responsible for that. So I may come back a little bit earlier to prepare for the temporal bone course,
Oh,
then
okay.
Clemens
Okay.
will
Okay.
finish off.
Got it.
Yes.
It's just because I think just the timing of the bone course for me and this kind of thing, I might have to leave.
Mhm.
Yeah. So if I met you, does the course starts like what, Wednesday morning?
Yes, it's Wednesday morning. So
Okay.
Wednesday morning and Thursday morning is the actual lectures and practicals. Then on Friday, just a few presentations. Then after tea break, which is 10:30, I'd reserved a slot for African Otology Society discussion. So it will
Oh,
half
that's
hour.
wonderful. Oh,
Yeah.
that's great. On Thursday?
No, on Friday.
Oh, on Friday. Oh, so the
Yes.
course will be, I'm sorry, the course will be Thursday or Wednesday, Thursday.
Wednesday, Thursday, yes.
Got it. Got it. Okay. Okay.
Yeah.
So then I would just meet you in Harare probably on, I'd have to come in. Would I come in like Tuesday night then, do you think? Is that better?
Yeah,
Would it be
that's
come in like
better.
Tuesday night? Okay.
Mhm.
And
Because
then
I
I
have
would
a
probably,
few lectures. I have a few lectures for you. I'll share with you the draft program. I think
okay.
soon then you can go through it as well.
Yeah. Okay. Perfect. Okay. That sounds good. So I just have to, yeah, I'll get that logistically figured out on my end. And then I would probably leave Harare on like Saturday,
On Saturday for Cape
Saturday or
Town.
Sunday,
Mhm.
Saturday or Sunday, somewhere in that range.
Okay, yeah, that's okay.
Okay. Yeah. Yeah. Let me work that out. So, um, okay. All right. That's helpful. Okay. Okay. Great. Yeah. Well,
Okay.
good.
Yeah.
No, I'm looking forward to talking with you guys more about the Otologic Society as it's trying to get up and running. It's, based on the meeting that we just had last
Mm.
week, I know it's going to take several months, to kind of just build sort of the nuts and bolts of it, kind of the structure,
Okay.
leadership and how we're going to kind of go about it.
Mhm.
I really want everybody's as much input as I can into that. I'll
Okay.
send you guys this weekend, the summary. I'm
Okay.
going to type up the summary notes from the meeting and send it out to
Sure.
everybody.
Sure.
And then the next meeting will be in February. So we'll at least have, before I see you, we'll have a couple more meetings
Mhm.
online. Yeah. Are
Okay.
Saturdays okay for you? I was trying to gauge too if Saturdays are good for most people.
Yeah, I think Saturdays are okay, especially the
Yeah.
time that
Uh-huh.
we normally put across. I think it's okay. It's only that both of us had travels out of Harare
Yeah.
that particular
Sure.
Saturday. So yeah, that's why we couldn't
Wow.
attend. But Saturday is perfect.
Okay. Okay. That sounds good.
Yeah.
Well, I'm sorry I can't make the audiology conference. It's just being away
Mhm.
for a couple weeks. It's just hard. I can't, it's hard to
Okay.
take 2 full weeks. But I hope that's okay.
No, it's okay. I need you on the temporal bone side.
Yeah. Well,
That's
I'll definitely be there for that for sure.
yeah.
Yeah. Awesome.
Okay.
Oh, good.
So
Well,
I'll
good.
share the draft program with you so that you can help me come up with maybe lectures and
Oh, sure.
any.
Yeah.
I would appreciate it.
Yeah, no problem. And you know what I can do too? When you send me a note, did I ever share with you our temporal bone manual? Sort of, I think we have an online PDF file.
Okay,
Might give you an
sure.
idea about stuff. And I'm happy to talk about anything you'd like, whatever you'd like me to talk about. I'm happy to cover it.
Mhm.
How
Okay.
many participants will you have at the course?
So we're expecting 20 participants.
Oh, nice.
Mhm.
That's
We're
great.
expecting 20. So I think from about 10 different African countries.
Oh, that's great. Oh, that's
Yeah.
fantastic. Oh, that'll be good. And they each get like a bone to practice on, or how do you guys do that?
Yes, so we are hoping each one will get at least 2 bones to
Okay.
practice on. Yeah.
Okay. That's
Hopefully
great.
they'll be up to speed and finish the bones on time.
Yeah. Yeah. That's
Because
great.
what we realized from last year, they are 2 different categories. Those who are experienced, who have been coming to us for a number of years, they want to do advanced stuff, and they are also with residents, trainees who are starting up. So we are trying to figure out on how to actually separate them so that the more experienced guys also get to do advanced dissection.
Okay. Okay. Oh, that's great. Oh, very nice. Oh, good. Yeah.
Sure.
How's your practice? How's everything going there? Obviously pretty busy, I imagine, huh?
Yes, I think it's been busy. I don't want to lie to you. It's been busy, and it's been more rewarding and more fulfilling. I must say, and I've been enjoying doing ears now. I think I'm more confident. Any ear, I
Great.
feel like I can tackle it, and most
Yeah.
of my patients also they are coming for review, and you can see they've markedly improved.
Yeah, that's great. That's awesome. How many implants now have you done?
So I've done only those. I've done 4 implants. I think the Botswana ones, the Zimbabwe ones, there's still lots of financial issues that they are still considering. So yeah,
Okay.
we have so far we've got 6 potential patients.
Oh,
So
great. Okay.
we may have the funds to implant them. I
Okay.
was also talking to some of the rich people in our country to at least sponsor a minimum of 10 per year. And one of the guys is willing to sponsor that. So I'll just pursue that in end of January and see how far I get with that.
Okay. Okay. Great. Great. How's the new baby?
No, she's okay. She's growing up so well. Now she's about 6 months, so she's trying to crawl. She's all over the show. Yeah.
And that's number 4, right? 3.
Number 3.
3.
Number 3. Yeah.
Right. Got it. Got it. Got it. Great.
And
Excellent.
I think that's the last one. That's that's the
Yeah,
last one.
it's the last one. Got it.
Yeah,
Got it.
yeah.
All right. Well, go get
I
some rest,
see.
my friend. Good to see you.
All right.
Good to see you.
Cheers.
And
Good to see you.
yeah, let
Have
me
a
know
good
what
day.
you need, and then I'll start
Okay.
working on the arrangements from my end. Okay.
Sure. Thank you very
I
much.
don't think for Zimbabwe, I don't think I need a visa, do I?
No,
I don't think I'll need a visa or anything like that. Yeah.
there's no need for visa. I think so.
Yeah.
I
Okay.
think there's no. Yeah.
Okay. That sounds good.
Okay.
Great. Excellent.
All right.
All right.
Thank you.
Well, get some rest. Have a good weekend. Okay.
Same to you. Bye.
All right. Nice to see you. Bye.